We're going to now turn to the rehabilitation process. And there's a lot of different kinds of information in this part. So I've done my best to divide it into different sections so that when you go back and review, you actually have a good idea of where you're at and what information is there. All right, so when we think about the rehab process, we think about length of stay in the hospital, and that is based on the all-important insurance authorization, right? So where's the money coming from for an extended hospital stay? What are the functional goals of the individual? And along with the goals, what sort of progress can we demonstrate that they're making? It's also important to note the people that are on the rehab team. So we have a physician, and that person is typically a physical medicine and rehab physician, or PM&R. We have a nurse, a variety of therapies, including occupational therapy, physical therapy, and speech and language pathology. There are often recreational therapists, a rehab case manager, and a social worker. Sometimes that person fulfills both roles, sometimes it's separate. And then neuropsychology and psychology, because there's a lot of psychosocial fallout that can be associated with a TBI. The first thing that happens is that there's an initial team evaluation. It consists of interview and observation with the person and often with other people who are in that person's life. A clinical observation, which would include a measure of range of motion, tone and tonal abnormalities that arose because of the injury, sensation, balance, and movement throughout the body. We're also going to look at cognition, perception, and vision. And we include vision there because perception is mediated in a large degree in humans by our ability to see, right? So visual perception. We're also going to look at performance of mobility and functional activities. So our ADLs and functional mobility fit in there. We're going to investigate endurance and pain, and the behavior of the person. So it's very comprehensive. Excuse me. In terms of cognitive performance, the team is going to look at identifying problems that affect cognitive performance. So these can include a wide variety of different factors like language, perceptual, motor, and visual deficits, the person's education and culture. So we always want to take that into account because it's going to inform us about their premorbid functioning, right? The medications that they're on currently and any past medications, any sensory deficits, and then physical limitations and previous expertise with a task. So we want to look at, what are they unable to do, but we also want to look at, well, were they be able to do this task before they had their injury, right? So not to fall into a trap of assuming that they could do a particular task when they couldn't do it before they got injured. Then we're going to set goals. And those goals are based on length of stay and the functional independence measure, now potentially replaced with some other measures on a scale of 1 to 7. And we're looking at the FIM in our evaluation class. So bring that into this whole picture. When we come up with goals, a lot of times you as newer goal generators and developers say, well, how do we know, right? And how long should the goals be for? And in the case of a TBI, we're looking at, well, how long do we have this person with us to actually engage in therapy and in rehab, right? OT looks at a lot of ADL areas, including eating, grooming, bathing, dressing, toileting, the basics. We also look at toilet transfers and tub shower transfers, so having that person be independent within the bathroom itself. And then we want to consider discharge destination. So is that individual going to go home? Are they going to go to a step-down facility? And what sort of caregiving availability is there? And as we look at the Rancho Los Amigos levels, you'll see that the amount of assist that a person needs really is dependent on how severe the fallout from their TBI is. So this is the first of 3 slides about the focus of OT. And we have a rich role in working with people with traumatic brain injury. We can work on splinting and casting of the upper extremity, and that is to maintain or help facilitate normal range of motion and to prevent contractures in some instances. We look at neuromuscular re-education, and we will be having a unit on NDT and PNF and looking at how do we work with somebody who may have some neurological muscular abnormalities. We look at cognitive retraining, participation in ADLs and self-care, and then bed positioning and transferring, and also mobility in a wheelchair. So all of those sorts of things. This second slide of 3 looks at additional OT focuses, including wheelchair positioning and mobility. So how is that person supported by their seating situation, and how are they going to get around in that wheelchair? Is it going to be a manual or an electric? What sort of controls will it have, etc.? Also, equipment needs, the wheelchair, but also bath equipment, any other sorts of adaptive equipment that they might need. Caregiver training, because in many instances, when the person goes home, they're not or may not be 100% independent. So we're going to spend a fair amount of time on caregiver training and education. And then finally, a home evaluation to determine how do we need to recommend that the home environment be modified or altered so that the person with the TBI is both safe and able to negotiate the home as well as possible. Then this third slide of 3 is optional IADLs and other occupations. And these are mostly dependent on, is there time to do this while we have the person under our care? And also, is there a need for this based on all of the factors we brought up before, right? Where are they going? How much care do they need? How much care is available, etc. So things that fall under this category would include meal prep, home management, money management, pre-driving, which is usually addressed post-rehab, post-hospital rehab, also pre-vocational, same thing, and community skills for getting out into the community and functioning in that environment. Okay, so now we're going to look at the scales and classification systems. We have 3 of them. We're going to go into them in different amounts of depth, one at a time. The first is the Glasgow Coma Scale, or GCS. So this is something that you need to know for the future, for your exam, and for your own knowledge, especially if you're thinking of going into work in physical disabilities or with people with traumatic brain injury. The GCS is this clinical tool that assesses the severity of the coma and the impairment of consciousness. The ratings go between 3 and 15, with 3 being the most severe and 15 being the most mild. So 3 to 8 is a severe TBI, 9 to 12 is moderate, and 13 to 15 is mild. It's one of the most commonly used scoring systems, and folks that are outside of OT use it as well. So it's a common language amongst medical professionals. And there's other systems that are used. This, like I said, is the most common, but just so that you know, the Abbreviated Injury Scale, or AIS, the Trauma Score, and the Abbreviated Trauma Score are other systems of rating severity of coma and consciousness. There's 3 aspects of coma that are independently observed with the GCS. The first is eye opening, and it's typically referred to as the E. The second is the best motor response, which is the M. And the third is verbal performance, or the V. The overall coma score is obtained by adding up the numbers from the E, the M, and the V. And as I said earlier, 3 is the least responsive, 15 is the most responsive. We're going to rate the person on their ability to open their eyes, and it goes from a 4 down to a 1. So 1 is that it's not happening. 2 is that they'll open their eyes to pain stimulus. 3, open their eyes to speech. Hey, Josefa, right? And then 4 is spontaneous eye opening. Verbal response is rated on a 5-level scale. 1 is no response. 2 is that the individual makes incomprehensible sounds. 3 is inappropriate words, so they are talking, but they're not oriented. 4 is confused conversation being more than words. And 5 is that they're oriented. And then we have a 6-point motor response scale. And when we say best motor response, we want to note, like, given all of their responses, what's their highest level of functioning? So 1, again, is nothing. They're not responding at all. 2 is extensor response, which is decerebrate posturing. And remember, decerebrate is worse or more involved than decorticate. So here we see this. A 2 is an extensor response. A 3 is an abnormal flexion response, and that is associated with decorticate posturing. A 4 is that they withdraw from stimuli. A 5 is that they can localize stimuli. A 6 is that they actually can obey the command to wiggle your fingers, for example. So that's the Glasgow Coma Scale. That's our first instrument. Our second instrument we're not going to spend a lot of time on, but it's good that you know about it. Its abbreviation is GOAT, or Galveston Orientation and Amnesia Test. It measures the cognitive level of patients post-injury, and it helps us develop a realistic recovery plan based on their cognitive level. A low GOAT score usually indicates that the person has had post-traumatic amnesia for a longer period of time. And increased duration of PTA means typically that there's more diffuse, or all over, or bilateral, 2 sides brain injury. So it's a more intensive injury. And the longer the person is in a confused state, the more difficult it will be for them to return to pre-injury cognitive levels. So the longer they're out of it, the poorer the prognosis generally.